Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
We spend 1/3 of our lives asleep. If we want to be healthy and enjoy a good life, we need to pay attention to the quality and the quantity of sleep. And it's when all the activities of our day are archived into our brains, and it's also when vital tissues in our body are being repaired. How much we sleep and how long we sleep affects several things. How long we're going to live, totally not kidding. We were talking about shaving off 5 to 10 years of your life if you don't sleep well. Our metabolism, our psychological well-being, and our general quality of life. It also affects how our bodies respond to specific illnesses and treatments. Sleep apnea, which we're going to go into quite a bit this evening, contributes to obesity, high blood pressure, diabetes, depression, and a host of other issues. During the next hour, we have experts answering your questions about sleep disorders and sleep apnea. As you know, this is a live program, so give us a call at 881-0013. You can also watch this show if you have to leave the TV. You can watch the show on youtube.com and just search for El Paso Physician Live, and you'll also be able to ask some questions. This evening's program is underwritten by Southwest ENT, which is ear, nose, and throat. We also want to thank the Texas Tech Paul L. Foster School of Medicine for providing our medical student this evening. And today we have with us Nicholas Martinez, and he just checked with me my cell number, and Nicholas is the one that sends the questions my way via this telephone. So if you see me looking at my phone this evening, I'm not being rude to the doctors. I am getting questions from Nicholas. So Nicholas, thank you so much for being here. And we also want to say thank you and major kudos to the El Paso County Medical Society, who's been doing this show for 25 years. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. It's interesting because I'll have some of these doctors on the show, and yeah, they're doctors, but I've known them for 20 years. We've been doing the show for 20 years. You know, he talks about farts, and he talks about diarrhea, and he talks about all kinds of things that nobody wants to talk about. And that's what's great about the show, because you get to hear those things on the show and go, I'm not the only one. It's great. It's the El Paso Physician. Thanks again for joining us. We have 3 different specialists on the show this evening that are going to talk about sleep apnea, but sleep disorders in general. And there was a quote that we were talking about just a few moments ago. Dr. Diaz was talking about for New Year's resolutions, a lot of us say, oh, you know what, we're going to exercise more, we're going to get into shape. But no one ever says, hey, I'm going to try to sleep more, but that's actually super important. We're going to talk about that this evening. We have with us Dr. Edward Ossie, who specializes in cardiovascular disease. And then we have Dr. Gonzalo Diaz, who specializes in sleep medicine. And we have back with us again Dr. Kevin Bright, who specializes in otolaryngology, also an ENT guy. I just love saying those words. But thank you so much for being here. And Dr. Ossie, I know that we talk about, we're often together with cardiology programs. Yep. And this evening we're here regarding sleep. So as a cardiologist, how is it that your discipline has to do with what we're talking about tonight?
It's actually quite huge. We have so many patients. In fact, the way I look at myself with Dr. Gonzalo Diaz is that I'm actually a referral for him, like a primary care physician would refer to me, because the prevalence of obstructive sleep apnea in all the disorders that I take is extremely prevalent. 40 to 80% of my patients with hypertension, atrial arrhythmias, pulmonary hypertension, stroke, heart attack, 40 to 80% of them have obstructive sleep apnea. So our field is extremely intertwined with the pulmonary sleep physician. So it's extremely important that we collaborate and treat these patients appropriately.
And when you're talking about obstructive, this is a physiological, something's in the way, sleep apnea. And the reason I want to say that is I know that we've got central sleep apnea as well, but sometimes it's nice to be able to picture that when we talk about that. Dr. Diaz, you are our sleep disorder guy. And so the other 2 docs said, if we don't know the answer, go to Dr. Diaz. So you're that guy, you get everything. But you really are the person that studies sleep, that this is what you do all day, every day. If you can explain to the audience at home My gosh, I don't even know how to explain it because it goes from, I haven't been able to sleep since I was little. I'm a horrible sleeper. But what do you do with people and patients, and what are some of the questions that are asked of you?
Well, we need to find out what's the cause of the insomnia. And basically, we're trying to find out if the patient has depression, they have a poor cycle sleep, they have a sleep apnea can be one of the causes of it. They can be periodic movements. There's a lot of things that can give you insomnia. And if you don't address the underlying cause of the insomnia, you're never going to control that. And if you just take a sleeping pill, it's not the way to treat it. Most of the time, we don't recommend a sleeping pill for chronic insomnia. We recommend a sleeping pill for acute insomnia. But for chronic insomnia, we have to find out the cause of it and treat the cause of it.
And treat the cause of it, and that's the magic.
That is correct.
That's the magic. Dr. Bright, we had you on, so you kind of work your way in endocrinology as well, but you're ear, nose, and throat guy. So you are the person who looks at structures and what's happening. And I know that we've got a toy that we're going to show some information on later on this evening. But in this world of sleeping, as an ear, nose, and throat guy, what are you going to bring to the table today? What is it that you study with sleeping?
So, as a surgeon of the upper airway, we take care of children and we take care of adults, birth through death. Like Dr. Ossi, I'm a heavy referrer to the sleep lab because constantly we see people and observe their anatomy and say you have to have sleep apnea. So my management of sleep apnea is surgical management, and it's surgical management of obstructive sleep apnea. To be clear, central sleep apnea, I don't have anything to offer, but we're looking at those patients that are not getting a good night's sleep because when they try to breathe, the air can't get in.
Right. And we have a list of treatments that you've been doing for years, and that's going to be really interesting once we get to that point as well. Dr. Diaz, I'd like to kind of start with you as the sleep guy. Frequent insomnia in the general population. We're talking about sleep apnea a lot tonight, but what are some of the different types of just in general sleep problems that the population has?
Well, the most common sleep problem that we see is in chronic insomnia, without any question. Now, what's the cause of chronic insomnia? As we mentioned, it can be sleep apnea, which is very common that most people are not aware of it. When the brain senses that you stop breathing and your oxygen drops, wakes you up at the beginning because it doesn't want you to stop breathing, doesn't want you to drop the oxygen. So it keeps you awake because the brain learns that if you are awake, you're not going to stop breathing. You do it only when you sleep. So it's a very common problem. Then another problem is like drugs can affect your sleep. Obviously, excess of caffeine consumption can affect your sleep. Periodic leg movements, when you kick your legs at night, most of the common cause of that is when you have iron deficiency. A lot of people they're not aware of it. And by replacing the iron, those periodic movements gets better about 70% of the cases.
And that's like restless leg syndrome?
That's part of it, the restless leg syndrome.
Okay.
And the key just to check the ferritin levels. If the ferritin levels are less than 50, you replace it with iron for about 3 months with vitamin C, and 70% gets better, and the sleep gets better with nothing else. There's no need for a sleeping pill. And like that, there's a lot of cases in sleep medicine that we can correct it if we found the cause of it.
Right. And that's beautifully said too. And when you're talking about the cause of it, and Dr. Ossi, I feel like this is a nice transition to you. Sometimes you can look, as a cardiologist, you're looking at the anatomy of a person, or if you're looking at different conditions that they have. And there is a point where you must have some kind of sleeping issues, some type of sleep apnea. When is it that you ask your patients to get tested to see if you have sleep apnea?
There are definitely certain conditions that we find that if we are treating the patient with medical therapy and we are not seeing an improvement, and the biggest one that you can pinpoint would be hypertension. So patients who are on what we call a multi-drug regimen, I've treated them with 2 or 3 drugs, and they continue to have resistant hypertension, you have to think about obstructive sleep apnea. We not only see that with hypertension, but we also see it with different types of arrhythmias with the heart.
Okay.
So one of the most common arrhythmias that I deal with is atrial fibrillation. which is an abnormal rhythm of the heart that predisposes you to fast heart rates and to stroke. And in patients who have obstructive sleep apnea, if it's not treated well, the therapy that I give patients, such as if I shock a patient back into normal rhythm, it is clearly associated that you have a very high incidence of having recurrence if you leave sleep apnea untreated.
Okay. So on that note, and I know we have so many different ways of treating sleep apnea, going to Dr. Bright, so piggybacking on what Dr. Ossie's talking about, he's got some people that have chronic conditions, they need to get the sleep apnea taken care of, so now they come and see you, upper respiratory, ear, nose, and throat guy. What are some of the options that you use to treat people like Dr. Ossie's talking about?
So I would answer, first of all, that they're typically going to have a sleep study done before they come to see me. And Dr. Diaz will emphasize that CPAP is the gold standard for treating obstructive sleep apnea, particularly in adults. Maybe a different story in children. Children, sometimes surgery has an earlier role, particularly tonsils and adenoids, and so forth. So I see somebody, and I will frequently observe in their physical exam, perhaps they're not even there to see me for their sleep issues, but you're looking at their anatomy going, this person has got to have sleep apnea. And in our town, the prevalence of diabetes is huge. We have this obesity epidemic going on. Obesity and diabetes together almost always has sleep apnea. So I will see these patients and say, have you had a sleep study? And frequently the answer is no, and then it's time to get their sleep evaluated. You know, we will emphasize weight loss in addition to CPAP therapy because that's a key part of the solution. And I see, besides children, adults where surgery plays an earlier role in people where CPAP may not be a good ideal option. A lot of people will come to me for surgical intervention as a first-line therapy because CPAP is really not compatible with their lives. In particular, I see over-the-road truckers that really can't be well treated for their sleep apnea in their rigs. We see anyone that carries weapons, whether it's soldiers or police officers, border patrol, where if you have sleep apnea and it's not being successfully treated, you may not be able to keep your job. Air traffic controllers, these people, they don't want to carry a diagnosis of sleep apnea. And when we use a CPAP, we're treating the sleep apnea, but if we are able to surgically cure it, send them back for a sleep study, verify that they no longer have it, a lot of those people's lives are much more intact.
And Dr. Diaz, this is a nice way of going into what you're doing now. You were talking earlier that we often dismiss sleep as being a part of our major health. And Dr. Bright was talking about you may not be able to perform your job, and some people may not know it's because they're not sleeping well.
Oh, yes.
So I'd love you to take that statement, as you will, and kind of talk about that. How does one know when they're not sleeping well? It sounds such an easy question, but again, I'm that person that goes to sleep 2 hours awake, 2 hours down,
Most of the studies show that when you sleep 7 hours, you have a better quality of life, you get less illness, and you live longer. People that doesn't sleep well, or the lack of sleep because of social reasons or job or whatever reason, the incidence of high blood pressure is higher, the incidence of obesity increase, you develop diabetes because you release a lot of hormones when you sleep that help you to stay in your normal weight. Just to mention some of the hormones that you release is melatonin, that you release it only when you sleep at night, and that protects you from cancer of the breast and cancer of the prostate in men. Another hormone is the growth hormone that you needed. 80% of the growth hormone is released only during delta sleep, and that helps you to repair all the muscle damage and also help you to grow in kids. If you don't have it in adults, or you don't have the right amount of growth hormone, you're going to have more fat and less muscle, because the growth hormone helps you to build more muscle and also repair all the muscle damage that you created the day before. So if you exercise, you could have a lot of aches and pains where you don't sleep well. That's what I was saying before. It's more, if you have to choose sleep or exercise, choose sleep. A lot of people wake up 1 hour before to go to the gym. It is a huge mistake. It's much better to sleep that extra hour than to do exercise.
Now, I'm a cardiologist here. You've got to be careful there.
I'm not saying exercise is not good. Excellent.
You just don't get up early in the morning. And
But
don't cut off
substitute
sleep
sleep.
to do
If you have to
exercise.
choose either one, studies show that when you exercise, when you sleep deprived, you use more muscle than fat as an energy. And the benefit of the exercise is not there just because you sleep deprived. I'm not saying exercise is not good.
Right. No, I
It's
get that.
excellent.
Right.
It's excellent. So
No, I completely respect that. So here's my question, and maybe I'm complicating it more than I should. And I'm going to use myself as an example. How does one know if they're getting enough REM sleep, if they're getting enough delta sleep, if you're just chronically a person that doesn't sleep well? And I know I'm just throwing that out like, oh, they don't sleep well. But again, that's me. I will sleep for 2 hours. I'll wake up at 2 in the morning and I'm just staring at the ceiling. My head's going. I don't know if I'm sleeping well or not.
of course
You know,
not.
I go to bed at a certain time and I wake up at this certain time, but in between, I was up 3 or 4 different times. So
Yeah, that's definitely
that's where the
abnormal.
sleep study comes in.
Yeah, that's what we have to find out what's the cause of that.
Okay.
Can be a lot of reasons for it. Can be from medical reasons, can be from psychiatric reasons, can be from sleep apnea, from paralytic movements. We have to evaluate medicines, alcohol. A lot of things can affect your sleep. And if you don't evaluate that, you're never going to get better. Now, how do you know how many hours of sleep do you need? The basic rule is when you're not active during the day and you don't feel sleepy, you're doing well. If you kind of doze off when you're not active, and you're sitting and you kind of feel tired, you kind of doze off a little bit, you sleep deprived.
You're not getting enough at night.
Now, 90% of the people needs between 7 and 8 hours.
Okay.
10% need less than 7 hours, 10% is more than 8 hours. But 80% is between 7 and 8.
So explain to me, and I feel like I'm just focusing on you, but it's kind of setting it up for Dr. Bright and Dr. Ossie too. Explain to me what you all do in a sleep study, physiologically. Do you have, you know, I feel like everybody's got these little things on their brains and you're looking at the breathing and they're hooked up to stuff. I have no idea. But what are you looking for during these sleep studies to see what
Yeah,
what
we
issues
put
people have?
electrodes in the head so we can see what kind of sleep you have. We check if you have stage 1, 2, 3, and 4 in REM of sleep. And then we check your breathing to see if you stop breathing at night. That is typical sleep apnea. And if you stop breathing, we try to find out if you have obstructive apnea or central apnea, because it's all different type of apneas. And then we check your legs to see if you kick your legs at night. That affects your sleep. Also, we check your oxygen. Some people drop the oxygen because of pulmonary problems or cardiac problems, nothing to do with the sleep apnea. That affects your sleep also. So there's a lot of parameters that we follow, and we video record the whole night. So we know exactly what kind of sleep they have at night.
Okay. And then from there, now we're going to go see Dr. Ossie, because Dr. Ossie said, you need to go get a sleep study. And so now, Dr. Ossie, we know that they have, let's say, obstructive sleep apnea. Really quick before I do you, because I want to, again, so there's obstructive, which again, something's in the way. What is central sleep apnea? Sorry, I totally put you on hold, but I figure if I say
That's
that,
okay.
we have to explain really quick what central sleep apnea is. What is that versus obstructive sleep apnea?
Obstructive apnea means that your airway close and the brain sends the signal to breathe, but you have an obstruction in the airway, so you cannot breathe. You make the effort, and then you wake up and breathe again. Central apnea, your brain doesn't send the signal to breathe. So you just stop breathing and your oxygen drops. Typical cases is congestive heart failure. It's very common to see central apneas. People with previous stroke, people who've taken drugs, narcotics, it's very common to see that.
So now this is a great way to transition to you. And I know we talked a little bit about this before the program, because we don't want to scare people, but we want to make sure that this is a big deal. So we were talking about sudden cardiac death, which can be related to a sleeping problem. So again,
Correct.
we don't want people to dismiss the fact that they're not sleeping well, but with the two things that Dr. Diaz was talking about, maybe it's a central sleep apnea, maybe it's obstructive, but when you're talking about sudden cardiac death because you're not sleeping right, take it from there and educate people at home why this is important.
That's extremely important. I mean, obstructive sleep apnea, we put monitors on people all the time. Patients come in, they're having palpitations, we put a monitor on them. They may not have any trouble sleeping, but at the end of the day, we're putting a monitor on them and we're seeing that they're having significant slow rhythms of the heart, or sometimes their heart stops. Or they develop a abnormal rhythm that we call a ventricular arrhythmia as opposed to an atrial arrhythmia. The ventricular arrhythmias come from the bottom chambers of the heart. They can be very serious. And the patients that start developing those types of problems are at risk for sudden cardiac death. Now, the term sudden cardiac death is going to be typically associated with the most severe cases of obstructive sleep apnea.
Right.
So when he tests the patients and they come back showing severe obstructive sleep apnea, they're having multiple episodes of apnea throughout the hours of the night, those are the patients that potentially could be at highest risk for sudden cardiac death. But all these arrhythmias are serious. We recently had a patient that was in the hospital that had a passing out spell, and while he was on the monitor at 5 in the morning, he had a 12-second pause.
That must have been central, or was that obstructive?
No, it was obstructive.
It was obstructive.
It
So
was,
physically,
we
something
feel,
wasn't letting the air
right.
through. Goodness.
But still, at the same time,
That's
I
a
mean,
long
a
time.
12-second pause is a significant, and there's probably underlying heart-related issues, conduction, electrical issues with the heart, because everyone drops their blood pressure and their heart rate at nighttime. 10 to 15% drop typically, but can be exacerbated significantly if you have untreated obstructive sleep apnea.
Dr. Bright, let's talk about treatments, because if we're talking about untreated, now we're talking about treatments. And I'll kind of go through the list. We were talking about tonsillectomy. That was one of the, anything from tonsillectomy to palatoplasty to septoplasty to turbinoplasty, base of the tongue surgery, and then one that you said that is 100% all the time is tracheostomy. So now that I just read through them all, what the heck are these? And let's start with tonsillectomy, because just as kids, I feel like everybody had their tonsils out. So tonsils, there's obstruction there, and then we can go into the other ones that we were talking about.
Sure. So think tonsillectomy, primarily children. Now, we do see adults with monstrously big tonsils and their airways are obstructed. We take those out and they breathe better, but the typical patient you're talking about is a kid. These are kids that wake up with headaches in the morning, they're tired all day, they're napping during the day, they're wetting the bed, they have behavioral problems. A sleep-deprived child looks no different than a child with attention deficit and hyperactivity disorders. So I personally feel like it's hard to even make that diagnosis in a child that's not sleeping well. So the answer for sleep apnea, typically documented with the polysomnogram, is to take out tonsils and adenoids in children. And it's extremely successful. And children aren't compliant typically with CPAP devices and the other alternative modalities. So that's the tonsil story. And it's no different in adults, it's just less common.
Right.
Then on that list there, over the years we've tried many different things. We've shortened the palate, we've removed the uvula, that's the little thing that hangs down in the back of the throat. People with badly distorted nasal airways frequently can't breathe, although I seldom see anybody where I operate on their nose and their sleep apnea goes away.
Oh, interesting. Okay.
I do see them get their nose fixed and be able to tolerate the CPAP device much more easily because the pressures are lower, the pain is less, and so forth. So nasal surgery, palate surgery, tongue surgery is a very up-and-coming thing in this era of robotic surgery, and so some of these people, their obstructive problem happens at the back of the tongue where another tonsil that we don't usually take out very often lives. And that,
Say that again. There's another tonsil at the back of the tongue, and I don't know about this tonsil.
okay, well,
Okay, let's talk about this
so
tonsil.
we have 4 tonsils.
Okay.
We have the adenoid, which
Right.
is the tonsil in the nose. We have the palatine tonsils that are the 2 we see on the side of the throat, and then there's a tonsil that's literally part of the back of the tongue, which seldom needs to be removed, but occasionally gets big, especially after the other tonsils have been removed, and can be addressed with Several different ways of addressing it.
So that's right at your airway.
Right.
So, okay, interesting.
And a lot of these problems, when it's not just pure obesity, is for some reason these people lose their muscle tone when they go to sleep. And you don't necessarily even look at their airway and appreciate something's wrong, but when they go to sleep, all their muscles relax, the tongue, the tonsils, the palate, all falls into the back of the throat, and they obstruct.
Okay. So that's the base of tongue surgery, and you were talking about the tracheostomy.
So a tracheostomy.
So that seems more involved, because when you think trachea, not that it's more scary, but it just seems more involved.
Really, the only thing we have that's 100% successful, and it's 100% successful because you completely bypass all the things that obstruct the airway. So a tracheostomy is a hole in the neck,
Right.
and we cut through the skin, open up the trachea, put a tube in that keeps that hole open. Typically in a sleep apnea patient, a different thing than in a cancer patient, a small silicone tube with a button on it. They close their collar up in the day, nobody knows they have it. At night they go to
But it is a
sleep and they
continuous open-
pop the cap.
That was the
So-
only treatment that we used to offer 35 years ago.
Goodness gracious.
And
Okay.
there's still a role.
Okay. And there's still a role for that. Interesting. Look at the things that I learn on this program. I love it. Dr. Diaz, I got a question here from the audience. We were talking about sleep studies. And this is Edward who's on the phone. So Edward, thank you for calling in. And it said he had a sleep study in the past, but with all the wires, it was uncomfortable and it interfered with his sleep. And he wasn't sure if that may have affected his study or not. Is there a study that may not have wires? And I know that you kind of described earlier what's attached to you, but let's say it's someone that just has a mental block against having stuff on, and they're not at home, et cetera, et
There's no
cetera.
question when you sleep in the sleep lab, you don't sleep as well as you do at home. But as long as you sleep, it's enough for us to know that you have a sleep apnea or not. And most people are able to sleep well in the sleep lab. There's a portable sleep studies that can be done at home, and it's less electrodes than the ones that we do in the sleep lab. What's the disadvantage of the home sleep studies? It's not supervised. We don't check the brain waves, so we don't know if they sleep or not. So if it's normal, we don't consider normal. We still repeat it. If it's grossly abnormal, then we consider a good test.
Okay. And that's the big thing too, because I think everybody needs to figure out what it is that the issue is. Dr. Ossie, I would like to talk, I know we talked about hypertension and we talked about high blood pressure and the idea that everything kind of goes down you're sleeping anyway, but I want to make such a point here because you designed some great questions before getting here and I just want to make sure we address those.
Sure.
So hypertension in and of itself is a problem. When we're looking at sleep, and we did talk about a couple of treatments and we're going to go into, and Grace, if you don't mind, if we can cue up the video, we're going to talk about another treatment too, but hypertension, if it's left untreated, and let's say that we do now know with the sleep study that sleep apnea is a major problem of this. As the cardiologist, where do you bring the team in, so to speak, to help this patient out? And you can think of a case study or not, don't give any names or anything, but a time when this may have helped.
Well, I mean, anyone with resistant, like we were saying before, resistant hypertension, I've already got the patient on 2 or 3 medications, and they come into my office with a blood pressure of 160, which is unacceptable.
Right.
And, you know, at that point, the American Heart Association says that all those patients should be screened for obstructive sleep apnea. And not only patients with resistant hypertension, but patients who have pulmonary hypertension. So remember that every time you go to the doc's office, they put a blood pressure cuff on you and they measure your blood pressure, right? Well, that's our systemic blood pressure. But within the lungs there's pressure as well. And if the pressure within the lungs rises, it can affect the right side of the heart. You can develop right-sided heart failure, swelling of your legs. And we can measure those pulmonary pressures through an ultrasound or an echocardiogram, which we do in the office or in the hospitals. And you can get an assessment of patients' pulmonary pressures. And anyone who has pulmonary hypertension should have a screening sleep study. So there's multiple reasons to jump in and get the team together, not only for pulmonary hypertension, but patients post-stroke.
Bingo, that's a good point.
Patients
Yes.
post-stroke, 80% of patients post-stroke have been found to have obstructive sleep apnea.
Interesting. That makes perfect sense. Right.
So pulling the team in, I mean, it's almost like there's just, like I said at the beginning of the show, 40 to 80% of my practice, when you talk about hypertension, pulmonary hypertension, arrhythmias, and we haven't even touched on coronary artery disease. So coronary artery disease, obstructive sleep apnea, is a risk factor for coronary artery disease, just like diabetes is, just like hypertension is. So patients that have obstructive sleep apnea are at higher risk for developing lack of blood flow to the heart. Your oxygen levels are dropping. The heart isn't happy. It's not getting oxygen. And you can develop a heart attack, or you can have what we call ischemic changes on your EKG at nighttime that are being monitored with a Holter monitor that we put on patients. I mean, we see all of that.
Dr. Diaz, and then Dr. Bright, I'm going to talk about this new treatment that is there. Again, lack of sleeping, and I'm going to other illnesses and treatments. How our body receives that. Again, if you can explain, I know I touched on it earlier, but what is REM sleep? What is happening during REM sleep? Because we were talking at the beginning of the program that sleep helps tissues repair. Sleep is where your body kind of goes into, okay, everything else is relaxed, I'm going to try to repair this and try to repair that, and try to make all these things that Dr. Ossie's treating a little bit better. In someone who's not sleeping well, losing sleep, and they never enter REM or they never enter delta, explain what REM and delta is and what happens during those two times during sleep.
Okay. When you go to bed, it takes you about 15 minutes to fall asleep, a normal person.
Oh, a normal person. Wouldn't that be grand? Okay, go ahead.
It takes you more than 30 minutes, you have a sleep problem. And then you go into stage 1 of sleep. It's a very light type of sleep. If you go into the room, you're going to wake up and you know what's going on. Then you go into stage 2, and then you go into stage 3 and 4. That's called delta sleep. That's when you release your growth hormone. And that usually happens between 30 and 40 minutes. And then you go from delta sleep, you may go into stage 2 or you go into REM. And the first REM usually happens between 70 to 90 minutes after you fall asleep. And that's when you're dreaming. If I wake you up in REM and I ask you why you're dreaming, you remember perfectly fine your dreams. Now, when you're in REM, your whole body is paralyzed, except for the diaphragm and the heart.
So your whole body's paralyzed except for the diaphragm and the heart. Okay.
So your brain is very active during REM. So you're dreaming that you're running, so the brain sends the signals to run. And your brain oxygen consumption is very high during that period of time because it's very active, except that it's paralyzed after this level that the whole body is paralyzed. So the brain sends the signals to run, but you are paralyzed, you cannot run.
Right.
And that's when you have most of the apneas that usually gets worse because all the muscles are paralyzed. So you have a better chance to have significant desaturation during REM in people with COPD or in people with sleep apnea. That's when you see most of the arrhythmias because of that significant lack of oxygen that happens in REM.
And that's something you're able to, with the sleep study, you're able to measure this during REM sleep.
That is correct.
And I'm just thinking about dreams I've had where I'm trying to run and I'm paralyzed, but that's a dream. And then you said earlier, stage 1, 2, 3, and 4. Are those stages delta stages? Are there different stages of REM?
Delta sleep is called stage 3 and 4. It's a very deep type of sleep.
Okay.
If I go into the room and you're in delta sleep, you're not going to wake up. I can turn on the lights and you're not going to wake up.
That has never happened to me. I have never been
You
in
don't have
that sleep,
delta
and I
sleep,
thank
then.
God I'm still alive.
Now, most people has REM sleep, even though
Right.
they're not aware of it. The fact that you wake up in non-REM, you're not going to remember your dreams. If you wake up in REM, you're going to remember your dreams. And that usually happens in people that put the alarm at 6 o'clock in the morning. They may be in REM at that time, and they may remember the dreams like that. But if you wake up on your own, which is the ideal way to do it, with the sunrise, nothing before the sunrise, you're not going to remember your dreams because you don't wake up in REM most of the time on your own.
Oh, I dream all the time and I remember them. I need to come see you.
I want you to
Man,
be
I'm
my
a-
boss.
Oh my gosh. I feel like
I
I'm
want you
waking
to
up
be my
in REM
boss.
all the time. It's like I remember that dream, but if you ask me 2 or 3 hours later, I won't remember it. But I'll wake up from a dream and I have to get up right now because I'm having, I call them stress dreams. I just want to get out of my dream, get up and walk around, then I try to go back to bed, and that's part of my problem, right?
Let me tell
But
you,
yes,
if
tell me.
you remember a lot of your dreams, it's not uncommon to see that in obstructive sleep apnea. And let me explain you why. When you have the apneas, the worst apnea happens in REM. And when you have an apnea, which means that you stop breathing, you're going to wake up to breathe again. That's the only way to breathe again. Your brain wakes up and breathe again. If you're in REM, you're going to remember your dreams.
Interesting. I need to come see you.
And at the beginning of the stages of sleep apnea, you don't sleep, and eventually you're going to sleep the whole night and the whole day. Because your brain is going to learn, this is enough, I'm going to sleep through it. I don't care, I have to sleep. But at the beginning, you have chronic insomnia. And eventually, you're going to sleep through the whole night, and then you sleep the whole day, or very tired the whole day.
How interesting. So even if you don't think you've got all the issues and all the background stuff or sleeping issues, sometimes you may have that anyway.
The patient cannot
Bright,
be aware of it. You're not aware of the sleep problems because you do it when you sleep, and you cannot be aware of it in your sleep.
Right,
Your partner can be aware of it.
right.
That
I
you
know
kick
I
your
dream
legs.
like no one else, and I wake up, I wake up so easily. The light sleeper part of me, and I know I'm getting quite a few questions here from the audience too. This is from Claudia, and I'm just going to throw this out to whoever has woken up at night and is unable to see. Is it possible to detect night blindness? So that's kind of not what we're talking about right now. Well, I guess the question is it possible to detect night blindness during a sleep study? If it doesn't pertain to what we're talking about, we can kind of skip that, but I just thought I'd respect that since it came in right now. Another question from the audience, we're talking about dreaming and REM sleep. If you rarely dream, does that mean that you have sleeping problems since dreams occur in REM sleep? Or like you said, you could be dreaming and you have no idea
if you don't
because
remember
you're a
your
perfect
dreams,
sleeper.
doesn't mean anything. It just means that you don't wake up in REM.
Okay,
As long as you feel fine during the day and you sleep throughout the night and you sleep your 7 hours and you feel fine during the day, your sleep is perfect. It maybe wake up once a night.
I want to be
maybe
that
it's normal.
guy. Yeah. Dr. Rossi. Okay, Dr. Bright. This is kind of a unique type of treatment. It's relatively new that I understand. So we have a video. Yes, go ahead, Dr. Bright.
Yeah, let's do one thing first.
Sure, absolutely.
Because we'll talk about this treatment, but this treatment is an alternative to the gold standard, which is nasal CPAP, which we really haven't talked about.
I think we need
You
to
know what? That's a
summarize
good
that.
point.
Yeah, let's
Okay.
summarize that. I think let's make it very simple.
Okay.
In kids, they have a sleep apnea as much as the adults actually. In the kids, the most common cause is enlarged tonsils or adenoids. And the treatment of choice is surgery, not CPAP. Okay? So always, 100% of the kids needs to be evaluated by the ENT. If they have enlarged tonsils, they do the surgery. If they don't have it, which is probably 20% perhaps or less, those needs to be treated with the CPAP.
Okay.
In adults, the first treatment of choice is the CPAP.
And why not treatment for adults? So I know that there's,
Because if you remove the tonsils in adults,
Right.
you're not going to take care of the sleep apnea. In kids, you take care of the sleep apnea in 70, 80% of the cases. In adults, if you remove the tonsils, the sleep apnea doesn't get better.
so tell us why.
Nobody knows.
Okay.
Probably because it's too chronic,
Okay.
the process, and the process is already there. There's theories that it's coming from when you're a kid and you have the problem, and you live all your life, and then it's not going to take care of it. So we don't know what's the cause of it, but the surgery is not the answer in adults. That's why the CPAP is the treatment of choice. Now, 75% of the people do real well with the CPAP. 25% doesn't tolerate CPAP regardless. And those are the cases that needs to be done something else.
Okay.
And we have three different choices. One is the appliance for mild sleep apnea. We can use a different type of machine that is more sophisticated. And now we have an Inspire. That's why we have something that is new. But those Inspire cases is only for those people who doesn't tolerate the CPAP. It's the standard of care at the national level.
So let's explain to those that don't know or haven't had this issue or are just new to this idea, explain what the CPAP machine is doing physiologically as you're sleeping. Maybe describe the tubes, describe the air that's being put. So describe what the CPAP
Basically,
machine
when
does.
you're trying to, basically when you fall asleep and you try to breathe, the airway closed. So you have an airway obstruction there, and the air doesn't go in. The CPAP is nothing else but positive pressure. It's air from the room, and push air into your back of your mouth and keep the airway open. Doesn't allow it to close. We keep a pressure of 10 centimeters of water. It can be 5, 7, 15, 20, depends on how much air you need to keep the airway open. And that works pretty good in 100% of the cases, except that 25 doesn't tolerate that.
Now, when you say don't tolerate, what does that mean? Are
They cannot sleep with the machine. They feel very uncomfortable.
okay,
They hate
okay.
the machine. They come to it. They don't like it. They feel uncomfortable sleeping with the partner and with the CPAP. A lot of reasons that they don't like to use it.
Okay.
And those are the candidates at 25% that we have an alternative that is inspired that we didn't have it before. Before we said, well, we offered you tracheostomy, and nobody wanted that.
Right.
But that's an excellent alternative.
Yeah,
Do
like
we
you said, that's
recommend
the
it
one
now?
that does work 100% of the
Yes,
time.
we don't recommend that anymore. But it's
Okay.
still some cases that we do it.
Okay.
Very difficult cases that they're going to die. We don't treat it. We do the tracheostomy.
Then you do that, exactly. Dr. Rossi?
The intolerance is the biggest thing that
Exactly.
we deal with when they come back after I've sent them. Now we know why you have resistant hypertension or why you're having these arrhythmias, but the intolerance to the mask is probably, the biggest thing that we see,
Okay.
that they have a hard time dealing with it.
Those patients with severe sleep apnea, they don't use the CPAP, are the ones that are going to see doctors more often. And they end up in the hospital more often. That's why the people say, well, most people doesn't tolerate the CPAP. No, it's not. The ones that don't tolerate, they go back to doctor frequently. The ones that
Exactly.
do well, they don't see them anymore because they feel better. Everything improves. The cardiac output improves, the blood pressure improves, the diabetes improves, and they even can lose weight if they follow the diet and exercise and they sleep well.
Right.
They lose weight, they feel better without any question.
And I love everything about that, and again, because it's a physiological fix. And Dr. Bright, so talking about that, in case the CPAP doesn't work, so you were talking about that is a traditional and still golden standard treatment for 75-ish patients. And so when we're looking at this new treatment, I don't know if you can throw a percentage out there yet, how new it is, or just maybe talk about this before we show the video. Maybe you can explain what this device does inside the body.
So for a subset of those patients that don't tolerate the CPAP device, we categorize, we're looking for the people who are really going to help with this surgery. So there's criteria for who can have it, and those are both from the research that went into creating the device and from the FDA application and from the third-party payers that decide who we're going to pay for this device for. Our criteria is, number one, you have to have sleep apnea, and it has to be moderate. So the number of times an hour that we don't breathe the way we're supposed to is 15 to 65.
Moderate to severe.
So that's the group of people. We're not looking for the real milds. We're not looking for the hopeless. We're looking for the ones that this device would help. So 15 to 65 times an hour, their breathing is disrupted.
That's a big variation, 15 to 65.
Yep.
Okay.
Agreed. And then the next criteria is weight. Some people are so heavy, there's no hope that this device is going to help them, so there's really no point in putting it in. And the measurement we use for height and weight is called the BMI. And the BMI number is something you can calculate and look it up on your phone and put your height and weight in. It'll tell you your BMI. And the BMI for all comers less than 33, for some comers with different insurances up to 35 at the moment. I expect those numbers may creep up slowly over the years as we get more and more comfortable with the successes and failures. And then the last criteria is they have to have a anatomy that's going to be responsive. And so anybody that's a candidate for one of these that meets didn't tolerate a CPAP, isn't too heavy, isn't too severe, I have to examine them under anesthesia and see if their anatomy is configured in a way that will get better when we treat it with an Inspire device.
Okay. So what I'd like to do, Gracie, if you can show the video. This video does have audio if it comes through. It looks like it's a commercial, and we apologize for that. It's not about that, but it does explain what this device does, and we'll have Dr. Bright go into that a little bit more too, but run it whenever you get a chance. And Dr. Bright, you'll see that coming up. We also have some slides. Here we go.
This is Mike. Mike has moderate to severe obstructive sleep apnea. After years of struggling with CPAP and constantly being tired, Mike felt hopeless. Then Mike found out about Inspire. Inspire is the only FDA-approved obstructive sleep apnea treatment that treats the root cause of sleep apnea with just the click of a button. Inspire is a small device that keeps your airway open using a gentle pulse. It's implanted in the body with 2 or 3 small incisions in a same-day outpatient procedure. After the procedure, Mike works with his doctor to fine-tune his Inspire. Once it's fine-tuned, Mike simply clicks the remote to turn on Inspire and goes down to sleep. While Mike is asleep, Inspire monitors his breathing. Every time he takes a breath, a gentle pulse moves the tongue out of the way and keeps Mike breathing freely. And more importantly, sleeping soundly, the way he used to. This has been a total game changer for Mike. Mike is getting more out of life and back to being his old self again.
So that's a happy guy. Everybody here kind of chuckled a little bit when he grabbed his wife and said, hey, I'm sleeping, goes outside and walks a dog. So that's a guy that can sleep, which is beautiful. Describing, even though there was an audio, and we didn't get to hear audio here in the studio, but you all at home, I think, got to hear it. When again, we have Gracie, there are 2 graphics that we have. There's a slide number 1, and if we can pull that up, and we can have Dr. Bright kind of talk over that, because it shows really in a still shot what that is. So here's the device that they were showing in the video, and Dr. Bright, can you kind of talk through that as well? For example, where is that lying right underneath the chin? Where is it implanted? How is it implanted, etc.?
So the device works by sensing when you're breathing. So directly below the device on the chest wall is a sensor between the ribs that detects breathing. That sensor is plugged into what's essentially a pacemaker, and then each time it senses that there's breathing, an electrical pulse goes up the electrode that you see extending up across the chest and out under the chin. That electrode is hooked to the nerve that moves the tongue. That nerve has branches that pull the tongue in and push the tongue out. During surgery, we find which ones push the tongue out and attach the electrode to that part of the nerve. And when the entire device is hooked up and the patient's healed a month after surgery, they have a remote control and they turn their device on when it's time to go to bed at night. And each time their body tries to take a breath, the tongue is moved out of the way to keep the airway open.
How interesting. So it's like electrical, not shocks, but electrical signals that are going into your body. How long has this been available? How often, I know we were talking about intolerance of the mask is about 25% of people who, and then you were talking about qualifications earlier. Is there an approximate percent of the population that is using these right now, that you foresee using these in the future? I know it's kind of a futuristic thing, it's relatively new, so it might be a question that's too early to ask, but from your side of things.
All right, so to start your question, you asked when it became available.
Yes.
It hit the market in 2014.
Did it really? Goodness.
Largely in bigger
Okay.
cities, largely in academic centers, until the numbers were big enough that the company began to move out to, sort of community-based practices. And I think a lot of us, Dr. Diaz and myself in this regard, don't tend to jump on every bandwagon that comes out because so many of them flop, and you don't want to be the guy that's pushing the thing that flopped. So I think we did our due diligence, watched what was happening, looked to see the numbers. The numbers look good, and about 3 years ago, we were able to bring the program here to El Paso. Since that time, yesterday we did the 115th in town, and so our program is vibrant and big. This is the second largest implant site west of the Mississippi in the United States. So,
Okay.
but 115 out of 850,000 people in El Paso, this is a small number right now, but
See, and I'm thinking that's kind of a
anticipated
big
to grow.
number. Yeah. So out of the 115, what are some of the issues that you may have heard about from the patients that have had these? Because again, it's new, and for those, I hadn't seen this until today. What are some of the issues that they have? Do they love it? And I know we're here, it's a medical show, I get it, but in general, it's just interesting.
Well, we have a number of people here in town who have had these implants placed, and without being paid, they run around and try to sell them to everyone because their lives have been so changed. And we didn't talk all that much about it because you don't die from it, but one of the things that drives people to a sleep lab is their spouse won't sleep with them.
Right.
And so this device, CPAP as well, will frequently bring a spouse back into the bedroom, and that's one of the things that people are most excited about is, number one, there's no snoring in the room, so the decibels have gone down, and number two, the spouse or significant other is willing to be with them. So that's a big thing the patients appreciate. They clearly like being, waking up refreshed in the morning. They certainly are very happy that they don't have to keep trying to use the mask, which many of them don't deal well with. And not always is it physiologic. We live in an Army town. PTSD is something that very much limits a lot of people from having things over their faces. And so there's many, many reasons why people don't want to use a CPAP device. Some of them are even lifestyle things. You need to have a place to plug the thing in.
Right.
And, if you want to go out and camp for a week, that's hard.
That's a good point.
So.
And Dr. Diaz, I know that we're rounding out to about 8 minutes left in the show, but we have not talked about psychological issues, and I'd like to talk a little bit about that, because we've got the sleep studies that I think will be not easy, but I would imagine easier to detect during sleep studies. But those people that just have issues and can't get outside of their head, so to speak, when they're sleeping. Let's talk a little bit about that with sleep disorders, kind of take away apnea for a little bit, and address that since this is a sleep show.
Well, depression is very common in society, and one of the symptoms of depression is the lack of sleep. They normally wake up early in the morning, they can stay in bed, and they feel sleepy during the day. Some group of depressed patients sleep the whole day, but they don't sleep. They stay in bed, but they don't sleep, and they feel sleepy, but they don't have that. So that's one of them. Obviously, anxiety can affect your sleep. It usually affects you to initiate the sleep when you have a lot of anxiety. Other thing that is very important, anybody who has the symptoms of depression, it behaves, is the same symptoms of obstructive sleep apnea. Even the whole psychiatric department rotates in the sleep lab, and the psychiatric residents now, they don't treat depression unless they rule out a sleep apnea.
Interesting. Okay.
If they have symptoms of a sleep apnea. The problem that we used to have before is the same symptoms of depression are the same symptoms of sleep apnea. You feel tired, you feel sleepy, you have headaches, you have no energy. They think they're depressed. But if they have the symptoms of sleep apnea, they ask, do you snore, do you stop breathing? They don't treat the depression, they treat the sleep apnea, and usually after 1 or 2 months, the depression symptoms improve. If the symptoms are related to the sleep apnea, now they treat after 2 months. And this is coming from the psychiatric department now.
Okay.
What else? And it can affect your memory. These people that have a sleep apnea, there's a study from MRIs that did 100% of the patients with severe sleep apnea that did an MRI, they have microbleeds now with no previous history of a stroke. Those microbleeds, it's strongly believed that it's going to give you Alzheimer's or dementia, and you're going to be more susceptible to have a stroke. And that's what you were looking at. These people had a sleep apnea, no previous history of stroke. They do an MRI, they have microbleeds, and they're not aware of it. So if you don't treat it, you have more microbleeds, and eventually you're going to have a stroke.
Microbleeds, that's just freaky to say that out loud. Since we are at 4 minutes now, we have a question on the phone from Raymond, and he's having difficulty sleeping at night, and he does take medications for anxiety and depression. Could his medications be interfering with his sleep?
Absolutely.
And these are quick fire questions now, so absolutely.
Absolutely. Some medicines can affect your sleep.
Okay.
Even some antidepressants can affect your sleep. It depends when you take it and what time you take it.
Okay. Would you be able to say that quickly on the air? Is it better to take antidepressants at night? in the
No, it
morning?
depends on the, no, I
the
don't want to mention
medication?
it because every patient is different.
That makes
Yes,
sense.
uh-huh.
Question here from the phone again. Can sleep apnea cause or increase the risk for dementia? You did talk about memory problems. Dr. Ossie, I know you're a cardiologist, but let's talk about that really quick. And let's talk about sleep medications and dementia as well. Who wants to take that? Dr. Ossie's like, not me. I'm the heart guy. Dr. Diaz, so sleep medications, and let's talk about some side effects of that. And I know it's super fast, so you were talking about trying to get people off medication.
It's highly recommended not to take sleeping pills for a long period of time. There is a lot of complications from it, and a lot of times, once you take the sleeping pill for a long period of time, you have not improved your sleep. What happens is when you stop it, if your baseline is, say, 4 hours of sleep, and you take a sleeping pill, you sleep probably 6 hours, but eventually you're going to sleep 4 hours. And what do? You increase your sleeping pills to sleep 6 hours, but if you stop it, you sleep 2 hours instead of the 4 hours. And then eventually you're going to sleep your 4 hours baseline. And that's why we don't recommend chronic sleeping pills. Some patients we use it, I'm not saying we don't use it, but we try to avoid as much as we can. Cognitive behavioral therapy works in about 75% of the cases where you get rid of the sleeping pills if you follow the standard of treatment with
certain routine, like a sleep cleanliness routine. Okay. Only reason I'm stopping you is that we're running out of time. Dr. Ossie, is there anything you want to get across before we have to close the show? And you know how this rapid fire works.
Yeah.
So go. She's writing down the number 1. Oh gosh, go.
Sleep apnea is not a myth. There are so many people that think that, that's
Some Mickey Mouse
ridiculous.
stuff, huh?
It is not a myth. It has real issues, real problems, and you need to get evaluated and treated for it.
Absolutely, and that's what this program is about. And I want to say thank you again to Nicholas. Nicholas Martinez, you did an awesome job sending questions my way, and thank you to the audience for asking all of those. I also want to say thank you very much to the Southwest ENT, Ear, Nose, and Throat. Because this is where the magic happens. You know, we figure out what's going on. You do the sleep study with Dr. Diaz, and then take it from there. I also just want to thank you, Dr. Ossie, as a cardiologist, as a sleep medicine guy, and as a, dear Lord, otolaryngology ENT guy. I really like it when we have doctors of different disciplines on the show, because it really shows what the team approach is. And if you are watching part of this program and like to watch it again because you missed some of it, you can go to PBSElPaso.org. You can go to watch and then find this program. You can also go to the El Paso County Medical Society website, which is EPCMS. Just think of the acronym, El Paso County Medical Society.com. And you can go to YouTube.com and look up El Paso Physician Live. And I think that you can search for it at that point by the search button. Anyway, I appreciate you watching. This is the 25th anniversary of the El Paso Physician. I'm Catherine Berg. Good night.